Hi everyone, and thank you for listening in to this webinar today. We'll be talking about two tools that can be used as part of chronic disease self-management to promote wellbeing and better health outcomes in chronic blood-borne viruses. Before I begin, I would like to acknowledge the traditional owners of the land on which we are meeting and learning today, the Wurundjeri people of the Kulin Nation. I pay my respects to their elders past, present and emerging, as well as their continued connection to land, sea and community. So today we'll be talking in a variety of different contexts around two tools that can be used supportively in general practice. One of those is the LiverWell app. It is an app that has been developed for the self-management of viral hepatitis as well as liver disease. And we know that, for example, with hepatitis B, that the rates of engagement in care and the number of people who are not engaged in regular care are not where we would like them to be, as well as the treatment rates for Hep C and also with liver disease growing quite quickly. It is something that can be quite useful in practice as well. We also know from hearing people's experiences that being diagnosed with viral hepatitis can be something where there's not a lot of information that is easily accessible. It can be really difficult to find information and quite overwhelming. And this is something that can be used at that point as well. The other tool that we'll be talking about is the PozQol tool, which is a wellbeing self-assessment tool for people living with HIV that can be used both independently and in general practice. And given the ongoing and chronic nature of HIV, it is something that is really important to be mindful of someone's wellbeing throughout that time. There are a lot of ways that you can support people to manage their health and wellbeing, and these are only two of those. But they are something that can be really useful to help inform discussions and conversations, and as well as sort of to promote ongoing management and communication between both doctors and clinicians, as well as patients. And it's definitely something that can't be understated is the importance of GPs and trusted clinicians recommending tools and avenues of information that they trust that can really help with uptake and ongoing positive health outcomes. So just to set up some context for our next two speakers briefly, and we'll go into a little bit more detail as well as some resources available around this later. But I just wanted to give a little bit of a brief overview of the LiverWell app, one of the two tools. And it is something that was relaunched. We had an update recently, and it's a free app that's available to support liver health and self-management of liver health. And there's two real elements to this. One is that it is a source of information. People can get questions answered and contact people for support. But there's also tools that can help people manage their own health. So things like being able to schedule medications, record results and visually track results over time, record notes and keep track of appointments as well. And it is something that was developed in collaboration with consumers that has had a significant amount of consumer input, which means that it is something that is quite relevant and has had that guidance as well. And I think it is just a really useful tool for both clinicians and patients to use together to help with that communication. So now I would like to hand over to Dr. John ODonnell, who is an S100 prescriber GP, and who's going to talk a little bit about the value of self-management tools with a bit of a clinical lens. So thanks, John.
Thanks, Isabel. In practice, when we're trying to treat people with chronic diseases, quite often the biggest problem is getting them to take some ownership of their treatment. Quite often they just want to come to the doctor and get the quick fix, which doesn't tend to work unless they take ownership of their treatment. It doesn't tend to necessarily progress as well in the long run. I mean, hepatitis C is obviously not as bad as it used to be in the past, but it's still obviously a lot of people with cirrhotic problems who need a regular follow-up. So any tool that can help to get people to take more ownership and control of their treatment is going to improve their outcomes. I feel it's very important that we actually involve patients in their treatment. And this isn't just in blood-borne viruses, but most of the chronic illnesses that GPs treat. So apps like this can be very important. Have you got any questions you'd like to ask me?
I was just thinking, John, while you're talking, I think that's such a valid point around, supporting proactive healthcare amongst patients. Are there any avenues or suggestions that you have for clinicians that they could sort of try to maximise that or begin to build some of that into their practice?
Well, it's a matter of when we have a consultation, is it quite often at the end of the consultation, the patient expects you to take on the burden of their illness, whatever it may be, and it's a matter of actually handing it back to them and saying to them, well, this is what we suggest, but what are you going to do? What decisions are you going to make in relation to your illness? So they can actually get them involved in the whole treatment process.
And are there any tools that you use to help support that? Maybe that varies by diagnosis or something that you use generally?
Well, there haven't been many good tools around to actually get patients around. Obviously, things are changing with much more technology now than there used to be. In the past, actually sometimes even getting them to use a diary has been useful in the past, if you can actually get them to record stuff in it and use it to remind them when they need to do things. Because a lot of the patients just forget that they need to do stuff. So like doing a hepatoma screening every 6 months for someone who's cirrhotic, they don't always come back. So if they haven't got some sort of reminder, how do you get them to do it?
Have you had any success with avenues in the past of how to sort of support those reminders and encourage people to return for those screenings?
Well, you put recalls in, and you can send them a recall letter. Sometimes, though, the real problem is that a lot of these our patients are quite transient, and you may try and chase them, but they've actually moved somewhere else or they've changed their phone number. So if they have something that actually helps them to take control.
Do you have any thoughts or advice around supporting patients through change and what that can look like?
Quite often it actually comes down to you've got to make it that people have to see that they're going to gain something from change. People won't change just because you tell them to. They've actually got to see that there's some positive outcome for them in changing. If they can see that there's something that they will gain from their change, they're more likely to do it.
Thank you so much, John. That's been really, really insightful. So now I would like to introduce Dr. Nicole Allard, who is currently the Acting Director for the WHO Collaborating Centre for Viral Hepatitis at the Doherty Institute, and is also an S100 prescriber GP with a focus on Hep B and culturally and linguistically diverse communities, who's going to talk a bit further on the GP perspective in regard to the cascade of care. So thanks, Nicole.
Thanks, Isabel. So I did put a few graphs together, which is kind of almost against what we're talking about today, which is about patient self-management. But it's really just to talk about why we're not actually going to get there just by looking at data versus actually we need patients to be in the driving seat of their own illness. So I don't have any conflicts of interest to declare, and I just wanted to acknowledge especially Jennifer McLaughlin. These are some of her slides, and the WHO Collaborating Centre team. So what can we learn from cascades of care? And then a little bit about hepatitis B and hepatitis C. And I haven't put anything about HIV, so apologies. But I do come from the Centre of Viral Hepatitis, not HIV. So this is the concept of a cascade of care. Cascades of care have been around since just before 2010, there were HIV cascades. And it's a concept of all people with the disease and people who are tested and aware of their status in the case of viral hepatitis, those who are enrolled in care, on treatment, retained on treatment, and virally suppressed. And really the last 5 stages of this cascade requires someone to be engaged with their healthcare. As John alluded to, there's different ways of getting people engaged, and not everyone's the same. So some people are really into numbers and tracking their health status, and some people just want to turn up and be told kind of what's next and what follow-up they're required. So let's think about hepatitis B, because if one could have a favourite virus, that is my favourite virus, which is not always a good thing to admit. But anyway, so if we look at Australia, we have around 230,000 people estimated to be living with hepatitis B, so about 1% of Australians. And we estimate that only 22% are engaged in care and 9.3% are receiving treatment. And we have a network of about 400 GPs across Australia who can prescribe treatment. And in terms of hepatitis B, it's disproportionately seen in communities who are born overseas, particularly in the Asian region or in Africa, and also in Aboriginal and Torres Strait Islander peoples. So combined, those two groups make up nearly 70% of people living with Hep B. And then we've got other people who are living with hepatitis B. And I mean, there's a diversity, obviously, in the population of who's living with hepatitis B in terms of where they're from. But then also within that, there's different levels of health literacy, different levels of computer literacy, different ability to use an app or to engage in a sort of electronic self-management tool. And when we look at the cascade of care, this is just from the National Viral Hepatitis Mapping Report for 2018, we see that in terms of people who've ever had a viral load test, so of all the people living with hepatitis B, only 50% have ever had a viral load test. Only about a third have had one in the last 5 years, and only 1 in 5 have had one in the last year. So we've got a lot of work to do in terms of engaging with hepatitis B, because it's unique in some ways that we're going to monitor for very long periods of time, and unlike HIV, we're not going to necessarily initiate treatment. That long-term monitoring means someone might be having regular blood tests for 15 years before we decide to put them on treatment. And during that time, they might partner, they might have children, they might move states, they might move GPs a couple of times. And in all of this, what we actually need to do is get to a stage where there's more empowerment for the individual to understand what tests they need and when they're needed. If we just look at viral hepatitis more broadly, and this is from a recent analysis of some data, so 1.6 million patient records in 3 PHNs in Victoria. And if we look at actually who should be screened for viral hepatitis, we've got quite large numbers. So basically, 250,000 people met the screening criteria, and only 72,000 of them had a hepatitis test. So this is people in the first stage of the cascade, going from someone who's at risk of hepatitis B to being diagnosed with hepatitis B. And this too, you might say, well, what's that got to do with patient management? They don't even know that they've been diagnosed. But considering in hepatitis B is more common in families. If we have people engaging in care, they might be able to advise family members, encourage testing within their communities, etc. And I think if we want to look at missed opportunities for people who had a late hepatitis B or a hepatitis C diagnosis, and when we mean late, we mean 2 years prior to liver cancer, cirrhosis or death. So a cirrhosis diagnosis is essentially a missed opportunity. Most of them had 70% of them had blood drawn, 88% had GP consultations, ED presentations, hospital admissions. So 90% of them had missed opportunities for care. If we then actually look at people who have diagnosed hepatitis B and hepatitis C, again, many different missed diagnoses for care, both in general practice and across the spectrum. So systems miss people with viral hepatitis, and that is another call to action that we need to empower people who have a diagnosis to know what sort of healthcare they need. And it's not for everyone. People have different thresholds, different abilities to negotiate systems, but we have to work on basic ideas of patient self-management. And this was just looking, probably less interesting at the kind of screening, the percentage screened in the various categories according to age. And just flicked past that unintentionally. And what we see is that in the older age group, there was a whole lot of people who really should have been screened. I mean, the highest group was in 30 to 34, and that's probably actually partly the effect of women being screened in pregnancy for viral hepatitis. Now, when we look across this spectrum, we think, we might make judgments of who's tech savvy and who's not. And so we might think of who the app applies to. And I guess we just have to think of needing a variety of tools to engage with people. There are other low literacy tools like the Hepatitis B story, for example, which is very pictorial and has a single page tear off. And that might be suitable for some people, and the LiverWell app might be very suitable for others. So just thinking about hepatitis C, and this is just some work from the Kirby, and this is just looking at uptake. So to 2018. And of course, 2020 was a bit of a year where healthcare generally across the board suffered in terms of both testing and initiation of treatment. But we can see that there's a variety of success in terms of how many people have been treated. And this is also from a similar Kirby study, but this is actually just looking at a group of injecting drug users and their engagement of whether they've ever had a sample of blood, a hepatitis C test, whether they've then gone on to have RNA testing, who was RNA positive and who entered treatment and completed treatment. So this is really just a lot of graphs to actually impress on you that there's a lot of work to do, and that without the consumer and without a consumer both involvement but consumer motivation or patient motivation, we're not actually going to improve a lot of these care statistics. I just wanted to leave you with a couple of quotes from a recent study we did in women with living with hepatitis B in pregnancy as they experienced the prevention of mother-to-child transmission. And I think Fatou, says it's a disease and grows and progresses in time, and there's no treatment towards it. It's a forever disease. Of course, there is treatment, but Fatou is unaware of it. And then Yuri, who's had hepatitis B for more than 5 years, and says, well, they say I'm a carrier, so does that mean I have it, right? So she's not actually really particularly sure of whether or not she has hepatitis B. And this is work done by Nafisa Youssef in our group, interviewing women and their experiences. So in conclusion, I just think we have to think of creative ways to engage people in self-management. I think it's really important to consider technology. It's important to consider written information. It's important to consider good holistic care by general practice, because we're certainly not going to improve those cascades of care without this in play.
That was perfect, and thank you so much. And it was actually such an insightful way of looking at the fact that, there's so many different avenues where you can capture people, and for every doctor and for every patient, that's going to look different as to what that is. And there's, these are two options and two tools, but it is a very sort of insightful and sobering, really, look into what kind of gaps there are. So thank you so much. And I thought that now might be a kind of a good time to have a little bit of a break from presentation, and just to sort of have a little bit more of a look at the LiverWell app and some of its functions as a potential tool that could help address some of the gaps that Nicole's just talked about. And then I'll talk about some resources that are available to assist with that briefly as well.
The new LiverWell app has the latest tools and information with added functions that make it even easier to manage your liver health. Navigate the app in English, Arabic, Burmese, Simplified Chinese, Thai, and Vietnamese. You can add upcoming appointments and see your past appointments. Add your own list of medications with handy prompts for the medication names, schedule them, and set reminders for when to take them. You can add your own test results, track, and even graph them to compare, as well as your own notes to keep them all in one place. You can call the Liver Line for friendly and confidential information about your liver health. Link to LiverWell news, events, and liver health information. Sign up to the LiverWell e-newsletter and keep in touch with links to LiverWell's social media. So download the new LiverWell app today, and for more information, go to the LiverWell website, liverwell.org.au.
And so if you do have clients and patients that you think this is something that could be useful for them, or it's just something that you want to have as a tool on hand, there are some resources that you can order online from the LiverWell website to use in your clinic, including a poster and an A5 tear-off prescription style pad, and that just has some sort of brief information and prompts for people around what they can use the app for and where they can download it, as well as sort of some quotes and testimonials, both from doctors as well as community members who've used the tool. So now I would like to move on to talking about the PozQol tool, and in doing that, introduce Timothy Kulik and Katrina Hilton. Timothy is a health promotion officer at Positive Living Victoria, and Katrina is here with us from Archers at Trobe Uni. So thank you so much for joining us, and look forward to hearing about the PozQol tool.
Great. Hi. Thank you, Isabel. I'm just going to get the slides started. Okay, that's Living Positive Victoria's logo. Great, and yeah, thank you for the introduction, Isabel. Yes, my name's Timothy. I'm from Living Positive Victoria, and yeah, and I'm a health promotion officer from Living Positive Victoria. And today, my colleague Katrina, from Trobe University, and I will be talking to you about PozQol, which is a scale that has been developed in Australia to help better value and understand quality of life for people living with HIV. And before I pass on to Katrina to talk about the scale itself and how to use it, I wanted to give a bit of a background on the concept of quality of life and how it relates to living with HIV. So I know that these concepts probably won't be all that new to many of the people in this audience, and so we can think of this as a bit of a way of rehearsing some of these arguments and having a bit of a public health promotion and social justice rant together. But essentially quality of life is a broad-ranging concept of health and well-being, which encompasses an individual's perception of their place in life and within the context of their culture, values, goals and expectations. So while good physical health will certainly make up part of what makes a good quality of life for somebody, a good quality of life will also depend on things like an individual's psychological state, their relationships, their community, and the opportunities available to them in life. So in a similar way, what this means for people living with HIV is often very similar to what makes quality of life for a lot of people. But the way I kind of think about this is in a similar way to while treatment, might be is crucial for preventing disease for people living with HIV. Viral suppression alone doesn't ensure a good quality of life. And globally, we know that people living with HIV experience high rates of non-communicable diseases, depression, anxiety, financial stress, and stigma and discrimination, all of which affect quality of life. And we also know that factors related to quality of life, such as poor mental health, stigma, and discrimination, have a negative impact on treatment adherence. So in this way, we can kind of think of improving quality of life for people living with HIV as part of a commitment to health equity and social justice. But as those are key principles of health promotion, we can also think of improving quality of life as a way of helping end HIV. And it's for these reasons that since 2016, there have been calls to include good health-related quality of life as one of the fourth 90s to UNAIDS treatment goals. Okay, so what do we know about the quality of life of people living with HIV in Australia? Well, according to a long-running national study, HIV Futures, most people have long reported an overall good health and well-being, and this score has always been based on responses to one general question, which asks participants to describe their overall sense of well-being, including physical, emotional, and mental well-being. And Futures 9, which was the last time that Futures ran in 2018, was also the first time that the PozQol scale was used to help, deepen our understanding of what that score entails. And this showed that 63% of people living with HIV reported experiencing a good quality of life. So while PozQol is a more nuanced measure, this overall score can still mask some of the diversity. And the survey also showed considerable prevalence of depression, anxiety, non-communicable diseases, and the impact of social isolation, stigma, and discrimination. And there was also divergence over different variables, particularly age. And so our national goal in Australia now is to raise the proportion of people reporting a good quality of life to 75%. And the rest of this presentation will hopefully deepen our understanding of what the PozQol scale is, how people working in primary healthcare can use it to better understand the quality of life challenges that people living with HIV experience, and some of the things that we can do to address them. I'd like to pass on to Katrina now, who can elaborate a little bit more on what the scale itself is.
Yeah, hi there. Thank you, Tim. Hi, everyone. I'd just like to really quickly begin by acknowledging the traditional owners of the country that I'm on, and I think we're probably all in different spaces around the place, but I'm speaking to you from my home in the Judging country. So I'd like to recognise those traditional owners and their continuing connection to land and waters and culture, and that sovereignty was never ceded, and to pay my respect to their elders, past, present and emerging, and also to any Aboriginal or Torres Strait Islander people who watch or listen to this presentation. And in a similar vein, and in the context of the work that Tim and I are talking about, I also want to acknowledge the contribution, the really, really important contribution of people who are living with HIV. The fight against HIV and AIDS relies really heavily upon people living with HIV putting themselves forward as subjects and participants in research. And our fight against HIV is heavily indebted to them. So firstly, I just want to give you a little bit of background about the PozQol scale and the PozQol project. It began because HIV organisations across Australia expressed a need for a short, practical and reliable way to measure their clients' quality of life. The project was built on the principles of the greater involvement of people living with HIV. So what this meant in practice was the study was a direct partnership with peer-led organisations who represent people living with HIV. People living with HIV had meaningful involvement in the conceptualisation and prioritisation of the domains of wellbeing that the scale covers, also in the development of the items, the decisions concerning the refinement of the scale, and their insights and those from other stakeholders supported the balancing of statistical rigor, conceptual accuracy, and practical use. The project happened across 3 stages. The first was a systematic review of the literature and currently existing scales, and from this, 4 domains of wellbeing were identified and a draft scale was generated. The second stage involved the draft scale being tested, firstly with a panel of 13 experts from people living with HIV or peer organisations, as well as 5 other HIV experts and stakeholders. And then secondly, via a survey that was completed by 465 people living with HIV in Australia. I think the slide has a typo in it, but it was 465 people, adult people living with HIV in Australia. This survey that they completed also included items from validated scales, and so their responses to the draft PozQol items were cross-examined with their responses to the validated scale items, which was able to show that the PozQol items were actually measuring what we thought that they were measuring. And also the participants completed the same survey a month later, and this ensured that the results were reliable and, not just sort of based on how they felt that day. So all of that to say that the scale can be trusted, and it has absolutely been developed with input from people living with HIV. And so we know that it measures, the things that are important to them, which is really important. And the third stage of PozQol was a pilot across 12 community and clinical settings to assess if it could detect changes in quality of life over time, which was a sensitivity arm of it, and also the usability arm was to see how easy it was for staff to use PozQol in their day-to-day work and whether they thought it was useful. Okay, so all of the results of the first 2 stages was the PozQol scale that we now use. It's a 13-item scale that covers 4 domains of wellbeing. These are a psychological domain, which includes mood, coping, and hope for or fear of the future, and self-worth. The social domain is about personal and social life, so things like belonging, support, and also covering social stigma. The health concerns domain is not about people's physical health or how healthy they are, but actually about how they feel about their health. So it includes things like health-related worries and how easy it is for them to manage HIV and their treatment. And the functional domain is about whether a person feels that they can live what they would call a normal life. And this includes things like independence, meaningful occupation, and a good standard of living. Each of the items in the scale is a statement about how a person living with HIV feels with respect to some aspect of the domain that that item is measuring. The respondents are asked to indicate how strongly they agree or disagree with each statement. And then on the basis of their responses, you can see how well they are tracking overall as well as within each domain. So the idea is if you administer PozQol at an early appointment or before starting a workshop or a program, you can see how someone is doing at that point. And then if you re-administer it after the workshops or after the program or on an ongoing basis every 3 to 6 months, you can then see how they're tracking overall and within each of the domains. So moving on to stage 3, which was the sensitivity and usability trial. Firstly, PozQol was sensitive enough to detect changes in quality of life over time. This was true for the PozQol scores, as well as for the overall. This was true for PozQol scores for overall quality of life, as well as for each domain of wellbeing. And also, this was true when there were relatively small sample sizes. So it is a very sensitive scale from what these results show. And secondly, regarding usability. Overall, most staff who used it found that it was easy to use in their day-to-day work. This included staff from across a variety of service models, including hospital and high caseload general practice clinics. And the staff that used it said that it was easy to use, it helped them better understand the client groups they worked with, it enhanced their communication with their clients, and it raised topics for important conversations that may not have happened otherwise. I think it's important for transparency to say that some staff did have challenges integrating PozQol into their day-to-day practice, and this was especially true for people in clinical settings. These challenges were mostly logistic, and I think they would be challenges you would find trying to implement any sort of new process anyway. And they included needing to set up new data collection and storage processes, running out of time during appointments to talk to clients about results, and not having a quick and easy way to calculate and use the scores, which we've actually tried to sort of fix with some of the things we've done in the interim period between then and now. So hopefully those ones aren't quite the issues that they were previously. And despite the challenges, there are some really compelling reasons to try and overcome them. Of course, focusing on quality of life is a really enormous part of achieving quality care and maintaining positive health outcomes. Clinicians who used PozQol in their practice, despite the challenges, reported a whole heap of benefits, including, and this is a direct quote from Dr. Jenny Hoy from the Alfred, saying that it helped them bring patient-centered care to the forefront of their practice and consider the outcomes of utmost importance to the people living with HIV. And I think that's really key. Other comments were that it revealed information they didn't previously know about patients or clients. It helps them identify patients who are not managing as well as they had thought they were. It opened up discussions about referrals to community support services, quantified information that they already knew but hadn't been able to track before, and allowed them to measure and track information over time about quality of life. Since the project's finished, there have been a few little developments. Firstly, we have built a website. The website has a lot of information and resources, including versions of the scale in 16 languages, which is great, particularly I think in Melbourne, where we've got lots and lots of multicultural people. It's got score calculators. It's got different tools on Excel where you can change the language and put it all in sort of on the fly. So some of those logistical challenges we've tried to address with these tools that we've created. And there's a Using PozQol in Clinical Services section that was created with input from clinicians who have been using PozQol in their practice. So hopefully it's got some information that'll make that a little bit easier and more streamlined. I think it's also important to point out that PozQol is now being used all over Australia by most Australian people living with HIV peer programs. It's being used in an increasing number of community support programs and some clinical services, as well as in research studies. And it is the indicator that is used to inform the Australian National HIV Strategy about quality of life among people living with HIV. And so all of this, I guess, means that there's a pretty high likelihood that if you have patients or clients living with HIV, they will have come across PozQol already, and someone might one day present to a consultation with the results of a PozQol survey asking for support. And it'd be really great if clinicians would, know what to do with that and how to support them. And I think that's a good spot to pass back over to Tim.
Thanks, Petrina. Yeah, because I think we wanted to include this slide as a bit of a conclusion and as a bit of a way to help give everyone a bit like an idea of what you can do once you kind of learn a little bit more about the quality of life challenges that your clients may be experiencing. It might not have been something that has previously come up with clients, or it might just be a way to start the conversation about how you can, about different services and resources really that are out there and available to help people living with HIV. And I realize I didn't give too much of a background on what kind of organisation Living Positive Victoria is and the services that we provide earlier. Living Positive Victoria is a peer-led organisation for people living with HIV. All of our programs are either all of our programs involve people living with HIV in the development and delivery of them, and it's often the first place where people living with HIV meet another person living with HIV, which can be a really empowering environment and a great way to kind of address some of those social wellbeing concerns and generally just help normalise HIV. So, we provide a range of peer and community support services that we that are targeted, and we aim to really provide to cater for all people living with HIV. So one example here, I guess, is members of our Taking Charge group, which is a social group for people aged 50 and over. And that group provides, different a way to kind of meet people and socialize and get some of that social connection, but also has like kind of monthly topics about health issues. And it's linked to a chronic self-management course that we run in partnership with Thorn Harbour Health that gives a lot of skills to help with managing the different complexities really that can kind of happen with aging with HIV and all the different comorbidities and issues that can kind of start to really impact on quality of life. So I thought it was a really good example. And I guess it's also a kind of example that people don't often I think we're, as a sector, we're very well aware that when someone's newly diagnosed or a new diagnosis, there's lots of need to help address the kind of psychological impact or the kind of coping for a new diagnosis. So, it's just an example of the kind of breadth of the kind of quality of life challenges. And in our futures as well, I think it was the 50 to 60 around that age cohort which had the most challenges for quality of life and those comorbidities. So we're really expecting to see improvement in a lot of the measures in the scale, in the PozQol scale, around social wellbeing, the impact of stigma, and how easily people manage living with HIV and treatment and their other health concerns. And we actually use the PozQol scale in our programs to measure this change. I played quite a bit of a role in helping administer PozQol and integrate it into our evaluation systems across our programs. And I can say that, even for an organisation like ours, which community orgs do struggle as well with the same challenges of being busy and integrating new data collection processes and things like that aren't really easy for us. So it's been something that we've been able to do. I think a lot of the tools on the website that exist now to really quickly calculate and understand what the scores mean have been really, really helpful. So just from my perspective and from the perspective of a lot of staff, it's been really useful. We used to have other measures, and PozQol is short and, very sensitive. So we're able to incorporate it into evaluation when people enter programs and then repeat over a 3 to 6 month period. And we can actually see change in that over that period. And another example is the peer navigation program, which has been incorporating peer navigators as support into clinical services to help provide referral into community services and help people guide people across the healthcare system. And we've been using PozQol in that program for over 2 years. And so we will be incorporating. I'll be using the data that Living Positive Victoria has gathered using with the PozQol scale in my PhD research, actually, to kind of see if we can measure that, kind of confirm that change in quality of life for participants of that program. So, it's really helped us, and what we hope to show from using PozQol in our services is that you can trust that it's a way to helping meet those challenges for your clients if they if that's something that you learn by using PozQol with them. Thank you so much for having us today. That was really the kind of message that we were hoping to get across, is that to think of quality of life as a way of extending your clinical care outcomes and how you can do that. So thank you so much.
Well, thank you so much to both of you. And it's such a practical tool that, you can say has such a range of application, especially in a lot of different settings, where it can really broaden that conversation beyond, that specific physical health focus, because there's so much more that's also so important. So thank you both for sharing that today. That brings us to the end and concludes our formal presentation. Just to wrap it up, I was just wondering if anyone had any final comments on anything from tonight that they wanted to share.
Just wanted to thank everyone for their input tonight. It was a really great session, really useful and informative. And yeah, thank you so much for your attendance and all the work that's gone into it.
Thanks, everyone. It has been a really comprehensive and insightful session.